Thanks very much for making the time to join this conversation today. This is an important topic. November is Men's Mental Health Month. It's Bonfire Night. It's Movember. Various different days on the calendar that we mark. And like all of these sessions that we do, shouldn't just be a conversation on one day or one part of the year in November. This is a serious conversation, and I'm delighted to have two other men with me to discuss this topic today. So we'll probably start there with some introductions. I head up the customer success team at Thrive. My name's Rich, and I'll be hosting the discussion, but I have the delight of also having our two other panelists today. And we'll start with Mark, if you want to give us a quick intro as to who you are.
Hi, Rich. My name is Mark Winterflood. I'm Wellbeing Manager for Hastings Direct. Hastings Direct's our insurance provider down on the South Coast. We have just under 5,000 colleagues. Very passionate. I don't think we talk enough about men's health. I'm really looking forward to the discussion today.
Fantastic. Thanks, Mark. Andres?
Yeah, I'm Dr. Andres Fonseca. By background, I'm a consultant psychiatrist. I'm one of the founders at Thrive, and I'm the CEO. And I have a lot of clinical experience looking after men. So
perfect.
We are.
Yeah, I think we've got three, and not just three perspectives. We're hoping that you will contribute to this session today. We've got various ways that you can do that in the chat, in the Q&A function. Ella from our marketing team will sort of be monitoring that as we go along, and we'll build in, hopefully, have to keep not just one person in control today, but two other people in control that will run to time, and we'll leave some time to answer questions that you might pose in the chat at the end of the session. So that probably makes sense to move into the discussion, give you an overview of what you can expect. And we're going to break this down in three themes today. So we'll talk about stigma, and I want to unpack that a little bit. I think it's easy just to kind of understand what you mean by stigma, but there's different components which make up mental health stigma. And we're going to explore some of those themes. Then we'll move on to the second section of the webinar, which is all around what we're trying to do here, which is create more of a conversation, more visibility, and encouraging men to seek help. And we'll hear different perspectives of how we might approach that, from some clinical considerations through to Mark's perspective from an employer that is doing this within the workforce, Hastings Direct, that he represents. We always start the sessions, or at least top and tail them, with some resources, because we know that some people that will be coming onto these webinars may be struggling right now. And these are a selection. There are many great organizations, whether it's Mind, Samaritans, the NHS. These are a selection of organizations, as well as obviously ourselves in Thrive. If you have access to our service, you can access support through the app. But we do want to showcase these great organizations and give you the opportunity, either note them down. You will get a copy of the slides and the recording after the webinar, and we'll finish on a reminder of these services as well. But for anyone that does need sort of more immediate support or visibility of services that can help, here are a selection of some of those organizations. We've got a great shot of you there, Andreas. We didn't consult you before using that one, so I'm sorry about that. But I wanted to, I think it's all too easy just to, make this conversation around stigma just to kind of gloss past it and not really unpack it. And I think in order to understand if we're making any kind of progress, and that is quite difficult to measure for various reasons, I think it's helpful that we unpack some of the components that may make up. So we have an umbrella term, if you like, that is mental health stigma, but what is it that actually can contribute to that? So let's try and explore and unpack some of these elements, and I'll probably turn to our panelists at different points in this slide. So if I'm looking over here, it's because in researching this webinar, I was drawn to one particular article, which is from the National Library of Medicine. It was an article from 2020, and it was looking at stigma and exploring and unpacking stigma as a topic and trying to understand what is it that's going on here for men. Why are people not seeking help in the numbers or not in proportion to the amount of need that's being presented? And unfortunately for men, and we'll come on to cover this, I'm sure it's not a surprise to you that have joined this webinar, are sort of disproportionately affected when we talk about the most severe consequences of poor mental health. So we know that the overall prevalence of mental illness, and correct me if any of these things that I say from a clinical perspective to your understanding, Andreas, are incorrect, but the prevalence of mental illness in men is typically lower than in women.
Yes,
Yeah.
that's correct.
But we do know that men are much less likely to seek help, and that's represented in various different data sources. So why is that? Like, why do we think that that is? And so if we unpack this umbrella term, and I'm just going to read this definition as from that article that I quoted from the National Library of Medicine in relation to social stigma. So social stigma refers to the negative attitudes towards and disapproval of a person or group experiencing mental health issues. And this is rooted in the misconception that symptoms of mental illness are based on someone having a weak character. And I think that really caught my attention because and then that maybe bleeds into some of these the masculine norms, which is also featured on here. So this concept, if it is a concept, that by somehow admitting, bearing an admission that you're struggling, that you have a weak character. I mean, what do we think about that as an observation?
Yeah, I mean that comes with that. I suppose that you were talking about social, public, but there is also in exactly that scenario that you just described, there's also the self stigma. So a lot of the time is that a person may have a perfectly reasonable attitude to other people having a mental health condition, right, and being very sympathetic and supportive. But when it comes to them having a mental health condition, that's when those kinds of things can arise, and they can see themselves as being less than, or having I mean, I like to talk sometimes about resilience in this context, and thinking that somebody who's, for example, gone through life without ever having anxiety or depression or anything like that, and all of a sudden something happens that may make them experience some of those symptoms, their concept of themselves can disintegrate, and that can lead to feeling even worse about themselves, losing confidence in themselves, and actually because they are ashamed, that's what may be a big barrier to then seeking help. And of course, as you might expect, that scenario tends to disproportionately affect men.
Yeah, the latter part of the where I was going to finish with this. So these preconceptions can lead to discrimination, avoidance, and rejections of persons experiencing mental illness.
Yeah.
So this is probably one of the most commonly discussed areas when we think about stigma. But of course, there are various other elements, whether that's cultural beliefs within particular communities, whether this is self-perceived. So what do I actually think about, what is my construct of myself, to your point, Andreas? Am I this person who is, for example, tough, resilient, isn't, and then when something happens, what does that mean for my perception of this construct of myself? And also professional stigma. So we're not talking about here, which I initially thought when I was doing the research around how this may present in a professional environment. We are talking about the medical profession in this particular context and how stigma might apply there, Andreas. Do you have any thoughts?
Yeah, absolutely. I mean, I was going to say, so if we made progress in general, just going back to the topic about the social, that's the one that I think we've done the best. I mean, I think there's still things that we need to do about that, and a better understanding of mental health conditions. But by and large, I think that's been fairly successful over the last, I'd say, well, since I became a psychiatrist, more than 20 years ago. I think you've seen an improvement there. I don't think we've seen much change in the self-stigma, in the perceived stigma. And also, this is the one that you were asking me about, the professional stigma. That is all the, I mean, not psychiatrists, obviously, but all the medical professions tend to see, tend to have a very negative view of people with mental health conditions, which results in poor healthcare outcomes for them. So there's a double whammy there. So people who with serious and severe mental health conditions are less likely to seek not just psychiatric help, but any help. You know, they're less likely to go to the doctor, And when they go, they tend to experience negative situations. So their experience tends to be negative. They tend to be dismissed. I can tell you for a fact from my own experience as a clinician that it's sometimes very, very hard for me to convince a medic of any description to see one of my patients because they already have that label of being mentally ill. Or when they're describing some physical symptoms, it appears to some of my colleagues, not everybody, but some, that it's impossible that they may have those physical health conditions because they have a mental health conditions, like one precludes the other in their minds, when actually the opposite is true. It's more likely that they will have a physical health care problem, and it's more likely that they would have neglected it for longer. And this is, again, particularly true in men who, yes, it's less frequent that they will have mental health conditions, but when they do have them, they tend to be more severe than women. So that's the kind of thing that yes, that definitely exists. I'll give you one clear example. If you look at any hospital in the land, all of the specialties are in the main hospital. You have radiology, you have cardiology, you have surgery, you have everything in the same building, except for psychiatry, which seems to be separate for some reason. Also, patients who go to a hospital for their cardiology appointment, for their neurology appointment, for anything, are patients, and nobody thinks twice about that. Whereas if somebody goes to a mental health unit, we call them service users for some reason. Right. Anyway, so those are a couple of examples of what that, I mean, I think that still persists, and that is still a problem.
Yeah, I'm sure there's not, and we probably don't have the time in this webinar, a simple answer as to how that could and should evolve and be influenced. But yeah, I mean, for someone just hearing that, whilst it doesn't make sense to me that you would treat that in a different way, but that's a practical reality of how you've experienced healthcare being delivered. So maybe it's a question of time of catching up. You know, you mentioned in social stigma, public stigma, we feel like we have made some progress, whether that's particular people, celebrities, employers speaking more about this. We seem to be making some progress, but by your own admission that there is still a challenge there.
Yeah, I think if all specialties were integrated, there would be more contact and less stigma. Because it's still segregated, I think that breeds the stigma, because they never, a normal medic in the course of their business, they say, well, that's nothing to do with me. I'll send them to the other building out there in the back because they're presenting with, they're confused or whatever. So even when you have delirium in one of the wards, delirium is a medical emergency, but it presents like a psychiatric problem. It presents with people who are confused, have delirium, basically have delusions and hallucinations, yeah? But they have a medical problem. Sometimes the psychiatrists get called and only to say, well, this person has delirium. You need to do something about it because this is a medical emergency. So even to that extent, you get pulled into those situations and have to explain to people that if you are confused, that doesn't mean that you are automatically going to be sent to the psychiatric unit out there in the back.
Yeah. Mark, I wonder from your perspective, is anything here that really resonates or you see within your employer for the employees that come towards you or maybe don't come towards you? Is there anything that's kind of standing out here? And do you think we've made progress in this area from your perspective?
I think it all comes down to the type of organization that they work in. So culture for me is really important, to having that open and safe, confidential space, allowing guys and men just to come forward and talking about how they're feeling, but that we're a long way away in comparison to our other genders within the organization. But I'm seeing seeds of growth. men are, and you give them the platform and you make the support for the tools and resources that are available frictionless for them to get hold of fairly quickly, it helps.
Yeah, absolutely. And I think there's a conversation certainly around the positioning, how you talk about these things, and we'll come on to talk about that as we progress. So I'm going to move us on. So a little bit of an opportunity for the audience and our participants to get involved here. So Slido, you scan the QR code on your mobile, or you can go to slido.com and use the hashtag there. Just interested, out of the people that have attended and are listening and watching the webinar, which of these areas resonate with you? So, which of these areas do you feel? And you can select multiple choices here. Present the biggest challenge to men seeking help, and hopefully, if that is active, we'll get some interaction in the poll. Cool. So yeah, see a little bit changing here going on. Self-stigma, self-perceived, how we perceive the issue seems to be the front runner. Masculine norms forming in that, and in this article, indeed, it, and I think this is happening anyway, but it proposed, the need to redefine, if you like, manhood in this conversation, and yeah. So yeah, I think we can see the top two being self-stigma and masculine norms. Social stigma, I mean, we alluded to that there might have been some progress in respect of the conversation. I certainly think there's more noise around this. And I think that permeates to various different levels of society, different organizations. And the professional one's just an interesting one to unpack. So thank you for engaging in that. We're going to move on to the next slide. So acknowledging that there is this challenge around stigma, that it is a nuanced thing. I'm sure some of these stats, when I say they won't be a surprise, they're quite stark when you look at them. But we acknowledge that the disproportionately the burden, if you like, the challenge of for men in relation to suicide, 3 in 4 people who died by suicide in 2023 were men. So we have help-seeking behavior that doesn't perhaps reflect the need, and people are seeking help later. And we have this really challenging issue that we're confronted with, which is how men are impacted, particularly at the severe and the severe consequences and everything that can be associated with that. So again, an opportunity to engage with this. So 21, NHS Talking Therapies, formerly IAPT. What percentage of referrals do you think came from men? 20%. Front runner at the moment. We'll let it settle a little bit more. Interestingly, it's 36%. So we are seeing men seek help, but perhaps, and again, it has to be a nuanced consideration, but by and large, you can see it's disproportionately affecting men when we're thinking about suicide. And still, we have some work, some ground to cover in respect of creating the environment and encouraging people to talk, to share their experience, and to seek help. So let's talk a little bit more about that. So this is from Bupa, and I thought this was just an interesting conversation point more than anything. So on the left-hand side of the screen, as I'm looking at it, percentage of people who have hidden a mental health challenge from their partner or issue. And you can see that by various age groups. But it kind of struck me here that, everyone has a different experience of their relationship. However, you've still got a high proportion of people, or at least 40%, or 43% for 25 to 34-year-olds, nearly 40% for 35 to 44, which is my group, who have hidden challenges. I mean, what do you think about that? You know, this is your significant other, someone you think you could share these challenges with, but people don't feel comfortable doing that. And I just think that that just stood out to me as something of one of the potential challenges. And maybe it is easier. Some guys feel more comfortable speaking to their friends or their mates or whatever. But we've got, for me, that's a challenge. I don't know, Mark, what you think about that, whether that's surprising, neutral.
It's not, Rich. I'm seeing more and more generations of employees coming in. Their level of expectation that their employer will help them, and a curveball comes their way. The reliance on the NHS is not as strong as the older generation. On our onboarding questions, when we ask the question, did you know we had a wellbeing program? The answer is fairly low. But when you ask them, do you expect your employer to support you? You have a curveball. It's one of the highest sort of scoring questions. So there is an element of want from the employee.
Yeah, there's desire. There's, yeah, as you say, on the right-hand side of the screen, people are asking for more support. And we know that there are sectors that are disproportionately affected by this. I mean, construction is one of those, but it's not the only sector where it is a real issue. So what do you think then? So one thing, this is a word cloud style poll. So one thing that you think as an individual can help break the stigma to encourage men seeking help. And then we start to sort of take the discussion into some of the ways we can encourage conversation, what we might consider. So just give you a few minutes to participate in this poll.
Well, while they're doing that, I wanted to comment on the previous slide. You didn't break it down by sex on that one,
No.
but I suspect, if you do, the majority of those who don't approach their partners are probably the men. And again, it might be to do with what we saw in the previous slide with the self stigma and also the masculine norms, which I think play into one another. So it's a bit of a double whammy for men in particular. So you know, both things are interplaying of another. So if I admit to this, if I'm not doing well, if I'm not able to fulfill the role that I have in my mind that I should be playing because of this situation, then what is my partner going to think of me? So that might lead to you not sharing it or trying to sort of overcome it on your own and not bother your partner with those kinds of concerns and carrying on your own and not even seeking help elsewhere. The thing about the employment, it might be that, you know, if that is available, then that is a route for you to sort of seek help without being quite discreet, you know, being something that so because you might be worried about those things, you know, going through something that you feel you can trust that your employer has put in place might be a way to you know, incentivize that help seeking.
Yeah, no, good point, Andreas. So yeah, we've got some good participation here. So normalizing conversations around mental health. I think education was quite prominent, culture was quite prominent. Just picking out anything that maybe is a little bit different. Privacy. So cultural acceptance, sort of recognizing some of the themes that we unpacked under this umbrella. Stigma topic, taking away the fear of negative consequences.
Yeah, that's an interesting one, isn't it?
Yeah.
I also like the role models, and I do think that we do have some evidence there. And the type of story that I think results in better help seeking for men is slightly different from the story that helps women, for example, seek help when they need it. So again, because this mostly comes from suicide prevention type literature. It is stories told by men about their difficulties when they were really feeling very low, and how they overcame it and how they actually sought help, what that help entailed for them, and how they recovered, tend to be a lot more likely to prompt help seeking than other interventions, for example. So there was a study done in the US which was based on videos of people who had attempted suicide, but thankfully, you know, it was not completed suicide, and how they were when they were in that situation, and just explain it to the camera, just the story, and how much they were struggling, and also how they overcame it, what help they sought, and how they came to actually be very happy that they had survived such a horrible event. Yeah, that seems to be very successful in terms of prompting men who are struggling to seek help.
Yeah, I can see that being a very powerful tool. And there's I forget the football club now, but there's been some really good adverts actually in terms of trying to capture this challenge of struggling with your mental health. And yeah, I think we're being quite creative, and even just thinking about the concept for some of therapy. I know we've had this
Yeah,
conversation, Andreas, about it's dangerous territory going here, kind of an Americanized view of chatting about your thoughts and things like that, which obviously will explore your thoughts, but maybe there's a different framing of that for men that some men will find easier to resonate with and engage with. Yeah.
yeah, yeah, definitely. I don't know if you want me to comment on that now
Yeah,
or
I think
later,
I
but
think we've got time just looking at how we're tracking. Yeah.
yeah, no. So again, talking from experience, the way therapy in general is portrayed might be off-putting to some men. It's just about sitting in a room talking to somebody, whereas the message, and that's why some of those videos that I was talking about seem to sort of hit the mark. Were about how you practically overcome a challenge, and it's not just about what happens in the room when you're talking to somebody, but it's about, you know, problem solving, making plans, executing those plans, and making progress towards a goal. And again, some of those stories that were quite successful in prompting help seeking were about how the recovery was and what their life was then after this difficult event. How, you know, many of their goals that had that many of the feelings that they had when they were very hopeless, that they couldn't achieve A or B or C, then turn out not to be true when going through a process of recovery. Then they were empowered to do the things that they wanted to do and achieve those goals. That seemed to again resonate better. Again, this is a bit limited because it was purely about suicide prevention, but we know that is an area of important intervention for men, and a lot of men will not seek help until, well, you may only see them after they have attempted to take their lives, and something very serious has already happened. So yeah, no, that's the message, that may be a different way of looking at therapy as a process whereby you are actually doing active things in order to recover, and you have specific goals that you're working towards, might be a better sell for men than just talking to somebody else, and by talking you're going to somehow be better. Yeah.
No, I think that's an interesting, relevant observation. And maybe Mark, when we come on to your sort of section, you could talk a little bit more about some of the initiatives that you've sort of helped engineer within the business to encourage the conversation and engage. So I thought, Andres, it'd be perhaps helpful to consider when we're thinking about this, how biology, you know, the makeup of someone may influence their experience of mental health. Keep it fairly broad, but obviously hone in on what you think is uh, of relevance and significance to kind of say on this area.
Yeah, I mean, well, we know it does for sure, right? Because there is that disproportion that we see. So we see the prevalence is lower. You see that, but when there's a mental health condition, it is more serious. I think somebody was saying that yes, the completed suicide is higher in men than it is in women, but attempted suicide is not, and the rates of attempted may be higher. So self-harm in particular may be higher, are higher in women. So parasuicidal behavior is one of the ways you talk about that clinically. Yeah, so that may be even higher. It is higher in women, that self-harming behavior, or the propensity for taking non-lethal overdoses, for example, is higher in women. so that is true, yeah. So we know that there's a difference there. There's a difference, and one of the things is that we know that men are more likely to use, when they are going to attempt suicide, they're more likely to use quite lethal methods, and they can be quite risk-taking. So we do know that there's a difference between the risk tolerance from men and women. So men are a lot less risk averse than women on average, yeah. Okay, we can only talk on average. So there's going to be exceptions to everything that I'm saying, and you might find women that are not risk averse at all, but they are rare, and you know the norm is different, and that leads to those differences. Also, we know that the tail ends of the distribution are a little bit different in men than women. Women tend to be, generally, when they have a mental health condition, they tend to be generally better functioning. So there's some things that are still working. Whereas in men, we tend to see a poorer function, particularly at the tail end of the distribution when we have the more severe mental health conditions. And again, men are more likely to experience a more severe presentation of a mental health condition. For example, if we talk about something as serious as psychosis, schizophrenia, men are a lot more likely to have that particular. So whereas depression and anxiety are a lot more frequent in women, so things that are to do with the negative affect are more frequent in women. Things like schizophrenia are more frequent in men. Again, these are very rare conditions, but they are more frequent in men. So there is obviously a biological difference there on average. And it is those things, is risk-taking, is the lethality of the methods, the way when you do have a mental health condition, even though it's less frequent, is more severe. And again, those things that are very general that we were talking about in terms of the masculine norms are not necessarily cultural, that some of them are driven because they're universal. You can see them being repeated in culture after culture after culture after culture. So you can assume quite safely that a lot of that, I want to be productive, I want to deliver, I want to go out and do something for my family and do something meaningful that is going to make my family thrive, is kind of quite baked in. You could argue, and I think there's evidence to suggest that is the case. So there are definite differences there that lead to a different experience, and also the way some mental health conditions present is different in men than women. So that even the symptoms of, for example, depression and anxiety, you can have a difference between men and women. And if you're very used to the most frequent presentation, which is the presentation in women, you might miss somebody presenting with anxiety or depression as a man, because the symptoms and the reports that they're giving you might be very different, and the way they're experiencing those symptoms might be different. So, for example, we do have some evidence that in men who are experiencing depression, irritability and the distress manifests itself very differently, perhaps with more anger, for example, and more irritability than in women. That's one difference. So you might see that more than in women. Women, you might see more, acts of self-harm, and men may be more for the same level of illness, may be more irritable and aggressive, for example.
Thank you, Andreas. So let's talk about how we might affect this and how we might consider this in respect of men's mental health. So I just wondered if there's, I think you've kind of illustrated at least one of those points there. From a symptom presentation perspective, there may be different things going on. Is there anything else broadly that one might consider in approaching? It might be about the language, it might be the way that we've talked about how therapy might be perceived in respect of help seeking. Is there anything else from your experience in sort of clinical practice, or just generally springs to mind of considerations when you're approaching this conversation when you're speaking to a man?
I mean, again, every case is different, and obviously what you do is you try to very much be in tune with the specific individual that you have in front of you, rather than automatically assume things. I think that's very important through, not just men, but women as well. So you cannot say, oh, women tend to be like this, therefore I'm going to approach it in a particular homogeneous way. I don't think that works. You need to sort of try and understand the individual that you've got in front of you. And I think that's universally true. So you might get caught by something that you think is true in the average and may make you blind to the person that you're talking to and their particular needs. So I think first and foremost, look at that. And this is no different from men and women. Look for what is individually present in this case. What are the needs that this individual has, and what are they talking about without trying to filter it out by, oh, I'm talking to a man, I'm talking to a woman. What are they saying, and what are their complaints, and what, just try and pay attention to the complaints that the person is making. Now, once you do that, you do know that these things can differ, and then you may have a hypothesis in your mind about what is going on, right? So, for example, if somebody's presenting with reckless behavior and increased alcohol use and that sort of thing, and you might say, well, is this person suffering from alcoholism or an addict, or is there something else going on that has triggered this? So you're trying to sort of very carefully explore that. And I think, yes, I think the way you do sell, there might be some of that self-stigma and those male norms that, depending on how you broach it, they might feel very threatened by your approach. You might not, they might be struggling to admit to themselves that they are struggling, that they have a particular situation, right? So, obviously you're not going to, let's imagine that you disagree with what they're saying that the main problem is. You don't necessarily say, no, actually what's happening here is that you're depressed, because you might lose them immediately, right? So you do have to engage them where they are and listen to that specific complaint that might be about some other frustration, something, or they might present with a physical health problem. They might present with, or they might tell you, I've got insomnia, I've got a headache, I've got, pain might be a presentation. There might be something else that they are doing, or poor memory and poor concentration, something else, or, I don't feel, my energy is gone and I cannot do the things that I used to be able to do. And by exploring it from that point of view and validating that, you might see a way in, rather than say, no, actually the things that you're telling me are more to do with depression than anything else. And that might shut them down. That might shut, I'm not somebody who suffers from depression. I'm telling you I have a physical health problem and you're not listening to me. Yeah. So because I'm not making the symptoms up. So what are you talking about? And that is a particular struggle for somebody like me, who gets a referral from a GP that has explored a number of things and says, actually, this man may need to see you. And now how am I going to sell it? Given that my job title is psychiatrist. So I've been in that situation many times, when you actually have to sort of explain that psychiatrist is a kind of doctor, that I'm not just interested in these things, and I'm not dismissing the symptoms, because those symptoms that I'm experiencing, they are real. Absolutely. No, everybody says, my doctor thinks it's in my head. Nobody thinks it's in your head, right? So you're not making it up, as it were.
Yeah.
And then you also have the other conversation of, okay, yeah, but everything is in your head. So any pain, any distress, anything that you experience is always going to be in your head. So if I isolate this nerve here in your neck, and your hand is hurt, your hand may be hurt, but you're not feeling it. So why is that? Because the pain resides in your head. So if I disconnect the nerve, you're not going to feel anything. So you have to sort of talk a little bit about those things in general, to try and get them to buy into this model, this more integrated model, that what they think their mind is and their body is not that different, and we're addressing everything that they're presenting with all together, and we're not dismissing these things that they believe are important by saying, you've got depression, well, I have nothing to talk to you about. If you think I'm depressed, this is not the place for me. You're wrong, is the misdiagnosis. That's the kind of thing that I think is important.
Just reflecting on that. So, I kind of brought us into this slide thinking about, can we generalize themes and approaches? And actually, really, it's about treating the individual who is in front of you in their individual circumstances. And because we are talking here, from a clinician's perspective, if I take it back to most of the people that will be part of this audience, possibly not clinicians, if someone presents to me making it real basic, setting the expectation that they're not a clinician. It's not your job to understand to diagnose, but to be supportive. Are they in distress? Do they need immediate help, or is this something that I can perhaps follow on with them, and have they sought help, and have they thought about doing these things? So whilst I came into it with this sort of anticipation that we would look at themes, obviously it's really about what's happening to that individual right in front of you.
It's important to be aware of those differences, because, for example, your risk assessment is different. Because you're aware of those norms. You know that you have a certain priors, but very, very important not to be blinded by categories and try to look at the individual needs of the person that is presenting with you. And I think that applies to both men and women. But I think, again, if you look at it from the perspective of, depression presents in this way, and you've got depression, you might lose some people. Yeah. And that, in my experience, has always been more of a difficult sell for men than for women to get there. Yeah.
Right. Mark, it's over to you. So explore this how you think is best, and then within that, if possible, he says explore as you want, and then says what he wants. If you could bring out some of those initiatives that you've really sort of developed and you've seen come to fruition at Hastings, that would be great.
Sure. So we launched the Wellbeing program back in 2017. The key principles have never changed. It's awareness and education, and then, if possible, an event to highlight what we do. The model we used was Wellbeing champs, or whatever you want to call them, but we decided to go with the word champion. And then a year later, we then introduced another layer of mental health first aiders. And I must admit, for those who have Wellbeing champs in your companies, it is like herding cats. They are volunteers. But once you start getting a good, passionate individual that wants to do the best for their department and their colleagues, then you've got a piece of gold. I've got just over 100. They're my eyes, my ears, and my voice. They are my foot soldiers. So they deliver all of the agenda, the initiatives, the campaigns, the awareness, days, weeks, and months, etc. And they do more than the communication we have on posters. Peer-to-peer support is becoming more and more important. A lot of colleagues, including men, don't particularly want to go and speak to their leader. They want to resolve the matter themselves. And that's where the champion kind of comes along. I'm a big fan of, you have a well-informed, and they're not experts, by the way. They're acquainted with the tools and resources. I don't expect them to be experts, but a well-informed Wellbeing champion is a well-informed department. So that kind of sets out the scene of where we are. However, when COVID hit, we were luckier than some. We already had a firm foundation of support there. We were able to signpost to like Thrive and our financial providers and the EAP and digital GPs. It was all kind of there. Champions and mental health first aiders were kind of looked after. I think the COVID has done more for the Wellbeing program than I could ever do in mine. Then go forward, 2023. I knew that there was a gap. I knew we didn't be supporting our male colleagues. What we wanted to work towards is a culture where our male colleagues is asking for support is seen as a strength, not a weakness. That's kind of the utopia here. I was very lucky. I was trying to work out what I could integrate, and we've got lots of great tools and resources, and I could pull out the support that there's for men. But that's when the Talk Club came my way. And for those who don't know what the Talk Club is, it's a charity based in Bristol. I know there's a number of other related charities around the country, like Andy's Shed, etc. And they trained up a number of our team leaders, and it's run by our mental health first aiders, our male mental health first aiders. If someone says to me, what's the proudest thing you've done since you became a Wellbeing manager? And I could say the menopause cafes, I could say the Wellbeing Champs development program, which we work on. But actually, it's this. I remember in November 2023, linking to International Men's Day, we had our very first, it's all virtual, it's 1 hour, and it asks 4 questions. The first question is, how are you out of 10? Do you want to talk through that number? Second question is, what are you doing in the last week that you're most grateful for? Third question is, what are you doing in the next week to support your mental fitness? And then the fourth question is, how are you now? And always, every single session, the numbers will have gone up. Now, the first one we ever did, I was as nervous as hell, and half the guys in there burst into tears. And that's when I knew that we had done the right thing. And actually, they weren't crying because of what they were going through. They were crying because somebody was listening to them. And actually, there were other men in the business that were going through similar situations. And from that, we carried on delivering them. In 2024, it kind of bumped around. You're only allowed to have a maximum of 10, and actually some of the groups, hardly anybody turned up. But you have to keep going. It's word of mouth that brings people in. And what we recognized is by the end of last year, we then increased the numbers by 2 a week. And it looks as though I'm going to have to increase the number by a third in 2026. I'm happy with that. That doesn't bother me. Some of the guys that come along, much younger generations coming along, and they're bringing their mates. One guy turned around a few weeks ago and said, I'd written letters to all my nearest and dearest because I had had enough. And because he happened to say that in front of everybody, we were able to get that support for him fairly quickly. And so it just puts a smile on your face and a lump in your throat when you know actually this is really having a big impact. And I've had not one single female colleague or other genders say to me, what about the women folk? They haven't, because everyone agrees. We just don't talk enough about men's health. And what else has happened from a sort of a good positive thing from it? I had no idea, but these guys are meeting up in the offices. These guys are forming their own groups, WhatsApp groups. They can talk to each other on the weekend. They're reaching out to each other. I'm seeing a big increase in the South Asian men, where, especially when, give you loads of examples, but one guy turned around and said his parents are wanting him to marry, and he's really under a lot of pressure, and it's really getting him down. And of course, mental health in the South Asian community is a little bit behind. But I'm seeing glimmers of hope, because you saw the other guys all linking in, sending hearts on Teams, and next thing you know is they've met up afterwards. So that's just one of the things that we've done to help and support, and we'll continue doing that. And as I said, it's word of mouth that does it, and events where guys can come along and join in. And in fact, to the point where I struggle to fit people in. This is where I currently am, and I'm happy to do that. So that's kind of the main initiative which will be put into place.
Thank you, Mark. I mean, I think there's, as you said, if there's one thing you could be proud of, there's plenty there in those stories. People, making a real, in some cases maybe life-saving difference to people who have found some comfort in being able to share their thoughts and feelings. I think there's loads you should be proud of in respect of the initiatives that you've helped bring in. I'm mindful of the time, and I've been told there's quite a few questions, so I have some other thoughts on this and potentially around different things that you've encountered when trying to bring in some of these initiatives, but I want to try and get to some of the questions. So I'm going to take us through. We'll spend a little bit of time on this. So people that are going to participate, if you could participate swiftly, please. So what initiatives can encourage men to seek help within the workplace? You've heard from Mark there about some of the initiatives that he has helped engineer or driven within the organization to encourage a conversation. Anything that, from your experience, people have found has helped. So drop-in sessions. I definitely think the sort of culture, I mean, I know that's another term you can really unpack, but creating the right culture within the organization. Just give it a little bit of time for other people.
Yeah, that's the idea of psychological safety, which means that basically you feel that if you have to disclose something at work, is going to be you're very likely to get support rather than being censored or being dismissed or that sort of thing, and that is a cultural thing that you can foster.
Yeah,
it's not easy, but for example, having the groups that Mark is talking about, I think that makes a huge difference to know that the company is supporting these very publicly. Just makes you feel more psychologically safe, I think. And because, you know, I think Mark has not said, but I do think that that's a big investment on the part of Hastings, because they are releasing people from work, from the floor, to do these things. And he's saying twice a week. Now he's considering 3 times a week. So the organization has to be quite serious. And the other thing that I picked up on what he said was, you need to actually work on it and not give up. And even if you don't have great attendance, you have to keep going and keep doing it. I think those are things, you know, the company's serious about it, and you can see it, and that makes you feel more psychologically safe. Sorry, Mark.
No, I was going to say, and it's a no girls allowed, and I'm really strict with that.
Yes, yeah.
I'm absolutely strict. I want it to be a safe and confidential space. You know, I have people saying, well, why can't we do it? No, because I think men will just clam up, etc. So, yeah.
And I mean, I think the data bears that out. Yeah, and again, it might be because of that self-stigma that we're talking about, and you might feel in that group more psychologically safe if you're sharing with other men. Sure. But you may not want to appear to be going through struggle, perhaps in front of women, and so because some men will be thinking like that. Having that strict rule, I think, is, again, in my clinical experience, that bears out. Yeah.
Sure.
Yeah, and yeah, we've got lots of different contributions here, definitely reinforcing some of those support groups, networks within the organization, role of mental health allies, mental health first aiders. So thank you everyone who's contributed to this and the webinars as well. So yeah, we have 8 minutes left. We're going to move on. This was more of a signposting opportunity, if you like, really. There's a link. You'll get a copy of the slides, you'll get the recording, but there's the ability to contribute towards, I guess, the evolving strategy in relation to men's health here. So this is, as individuals, as organizations, you can contribute to this. So this is an evolving piece. We are learning about how we can better position this, how we can better support men. And I know, Mark, there was elements when you look at your strategy, and you've kind of delved into this as well in looking at some of the reforms or proposals from the government around strategy relating to men's health. So if you do want to get involved in that, there is the opportunity. You can do some Googling, or you can click the link that is hyperlinked at the bottom of the slide there. There's a couple of slides about Thrive, but I am going to breeze through this so that we can get to some of the comments and questions. So for those of you that have access, we're just going to show you how that looks. For those of you that don't, we are in essence a digitally enabled mental health service, providing support through an app, whether that's tools that can help you manage some of these stresses, manage symptoms, or you need to speak to a therapist. We approach this by taking a proactive approach, in that we reach out to people that are struggling or identify themselves as struggling and try and get them into support as soon as possible, if that's the right treatment approach for them. So I'll whistle through because I do want to get to the questions that we've got in the chat. And if you do have access, you will have an employer's access code, or if you perhaps are part of a charity, you'll have an access code that you can either speak to us by contacting us, or speak to one of your ambassadors, usually HR, Wellbeing, someone within the organization, maybe the intranet where your access code is. So that's the best way of doing this. I don't know if either of you are keeping an eye on the chat. I've seen some names I recognize there. How should we pick these up? Let's have a look. Go back. Some hellos, fantastic engagement. Okay, maybe this one's yeah. I don't know if it's an easy answer, but from Phil. So thank you for the question. So how can we help combat stigma in the workplace? E.g., if people are afraid of lack of progression or perception if they come forward and are labelled. Mark, I don't know if you want to talk to some of the themes that I think we've addressed some of those things that organizations can do to make the conversation more acceptable, psychological safety. Is there anything, sorry to pick on you, that comes to mind in in
I
that?
think leaders are the most, from my experience, leaders are the most crucial people you have in the business. If they're compassionate and knowledgeable and they give that safe space to the individual, then that should be fine. But it is all about the leader and the culture.
Thank you, Mark. Okay, so I'm going to read through. Andres, I don't know if you've got option to have a look at the Q&A on my machine. For some reason, it doesn't seem to be
Yeah,
letting.
I can see it. Yeah. Can you not
Yeah.
see it at all?
No, not on mine, just the comments. But there's a comment here, Mark. Are you a trained counselor or therapist?
I just saw that from Emma. No, and one of the things we're very clear about when we have our sessions is we say to people, this is not a counselling session. I'm not a therapist. There are no couches. Because you can quite easily, the guys can quite easily go off into what is really going on. And you have to then, that's where the support network that you have, the tools and resources you send to them. So it is easy, but actually most guys, if not all guys, respect the guidelines when they attend the talk club.
Thank you, Mark. There's a comment from Eugene. Hi, Eugene. So this is around sort of labels that we put on things. So certainly studies showing that people prefer the term patient and find service user patronizing. This also creates a disparity in health. However, in some circumstances, like counseling, patient would medicalize more minor mental health presentations. So
No, that's absolutely true, and I agree. In counseling, it's probably not appropriate to call somebody patient. I was referring purely to a medical context. So when you're seeing the psychiatrist or when you are somebody who's using psychiatric services, the term service user tends to be used, which is not used in any other medical service of any sort. That was my point. But yeah, I mean, if you are in therapy, you're seeing a counselor, you're technically not a patient really. Under those circumstances, you are usually a client is the way that therapists tend to refer to people coming to see them. So yeah, no, that's absolutely valid.
thank you. Andreas, can you do us a favor? Is there any more in the Q&A rather?
Yeah, so I mean, there's a few there. I don't know which ones you want me to take. There's one from Phil saying, "How can we help combat stigma in the workplace?" If people are, I think we sort of addressed that one. I think also the audience has helped us address that one. This one here. Here, therapy is very helpful for many people, even if you don't have a clear mental health issue, but knowing where to go to do that seems difficult. What are your thoughts on knowing how and where to find this support from a trustworthy source? There are also concerns of genuine help from someone you are paying money to at the end of the day. Certain apps which don't sound trustworthy, or going through the GP or something else. That's a very multi-pronged question. That is difficult. I fully agree. I mean, how to vet it? I mean, I do think that therapy can be helpful for everyone. I do think that you do have to have some kind of symptoms to treat. I don't think it's just for everyone for all reasons all the time. That seems to me to be an American model, which actually I do think, I mean, I think that the person that's asking the question has the same instincts that I'm going to talk about, which is there is a profit motive there. So if I'm a counselor, I want everybody to be a potential patient so that my my pool of eligible customers all immediately grows. I do think that you do have to have some kind of a specific issue that you're going to sort of focus on, because I think for therapy, for therapy to be meaningful, I think one of the most important things is to define clear goals that you're going to achieve through therapy. I think that again the evidence bears that out. If you just go to therapy with free-form discussions, that doesn't seem to correlate with any good outcomes, really. So if you have a clear focus and something that you're trying to address is good. In terms of trustworthy, yeah, I mean your GP, NHS talk therapists will have it. Some organizations like the people like the BACP, they have some accreditations that you can sort of look at and then take it from there. But I know it's difficult. I mean, certain apps don't sound trustworthy. So again, apps that use a marketplace model, I'm worried about, because again, the motive is to keep you engaged and keep you going to sessions and taking money off you without necessarily a clear goal. So it just depends on how it's set up. I'm going to say something about Thrive. In Thrive, we don't do that. We don't charge per session. We try to sort of accommodate clinical need first and be driven towards achieving some kind of an outcome. So if you are going to a therapist, if there's no clear structure and no clear goals and outcomes, I would be very worried. And that would be the cleanest answer that I can give in a short space of time. I have one here. My husband suffers with his mental health, but refuses to go on antidepressants. How can I help him? I'm on antidepressants myself, so how come it's okay for me to be on them, but not for him? I mean, that's a general question that you might encounter, again, mostly with men. It would be about, what is the nature of that resistance? Is it because it threatens some of that self-concept that we were talking about? If you go on the antidepressants, are you admitting that there then is something wrong with you, or is he quite happy to admit that he's he is depressed, but he refuses to go on antidepressants? One of the key things is to explore the nature of the resistance. What is the meaning of taking antidepressants for him? What does that mean? And from there, if you are able to sort of figure out what is the nature of that resistance, you might figure out a way to overcome it. And this is in general. So many times you have these barriers to help seeking, and don't assume what it is. You need to ask and explore what is the nature of that resistance. Why are you worried about doing this? Why are you worried about taking antidepressants? What does that mean for you? What do you expect to happen? What is the fear? Would be one way to explore it. There's a few others, but I don't know what you want me to do.
Yeah, I'm just going to, so just to say, obviously we've run over slightly. Maybe we pick one more. Mark, if you're okay to, I want to say thank you to you, but I don't know if you have to get off right now.
No,
Another meeting.
I'm fine.
Yeah.
Okay.
Okay. So maybe one more, Andreas, from your pick of the Q&A. And sorry for those that we haven't got a chance to get round to, but we really welcome your questions and appreciate that you've engaged.
The truth about maintaining peace and good mental health. Yeah. I don't know how to answer that one. So
No, I was struggling.
Again, it says here, if men tend to exhibit more anger and irritability, this is obviously an overgeneralization, but for what it's worth, it is true. When they're stressed, anxious, and suffering from mental health conditions, are there any specific solutions or treatment for that? So the fundamental treatment tends to be the same once you have the right problem. So Rich was saying that diagnosis, the diagnosis has its role. So you do have to try and figure out what it is that you're trying to treat. And that gives you an idea about prognosis and an idea about management. However, as I said at the beginning, it is about adapting that general idea that you've got about how to manage, say, depression to the individual that you've got in front of you. So that's going to be part of the problem. No, I mean, it is part of the work that you're going to be doing there is allowing them to realize that irritability and anger and feeling very guilty about having like an argument at home that they regret because of no reason, because their patience is short, allowing them to understand that is part of this depressive condition, whatever you want to call it. I mean, again, you are trying to sort of translate or help them understand their condition and frame it in the right way so that you can take it forward. So if they recognize that is a symptom of their condition, then you can then start with working with that condition. Does that make sense? So that is the work. I'm sorry, I don't have anything pithier to say about that, but that is the work. Yeah.
Yeah. No, I mean, this is necessarily a prescribed treatment, but I do for fitness, boxing training, and to get that aggression out, that stress, that I know it's danger of generalizing, but that I know for fact at the gym, I get people coming up to me who train boxing training who say that one of the primary reasons they train is for their mind. And that allows them to get things out. And I'm not saying, there's cognitive based approaches that sit on top of exercise, but we do know that exercise generally is very, very important.
I was going to say one of the most successful forms of treatment for depression and anxiety is exercise. And there's evidence that exercise alone, without any other intervention, can be very helpful, particularly in depression. There's a technique called behavioral activation that mainly involves exercise. And that can be very successful. And it can be very successful with men. You can definitely sell that to men as a form of treatment. I've done that, so I know that it can work.
Cool. Right. We'll close things off. Thank you. I can see a good portion of people have hung on, so hopefully we've addressed as many of the comments and questions that came in. Thank you very much for your participation in the webinar. Big thank you to you, Mark. Hope you've enjoyed yourself. It was good to hear from you. I think some really useful insights for other employers out there, and plenty to be proud of in respect of bringing that to fruition. Andreas, thank you very much.
Thank you
for lending your expertise, and we look forward to seeing you next time on the next webinar. So thank you and have a good afternoon.
Thank you very much.
Cheers.